Good afternoon. I'm Reem Ali, a Vice President at the Health Policy Institute of Ohio. Thank you for joining us for our online forum, What's on the Horizon? Connections between Racism and Health. I will be joined by Amy Rowling-McGee, who is the president of Hpio, and she'll be helping in introducing our speakers this afternoon and assisting with questions and closing out our forum for the day. Hpio is an independent and nonpartisan organization. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable spending, healthcare spending in Ohio. I want to thank our core funders who advance our mission with their steadfast investments in our work. And I also want to thank our 2021 Forum Series sponsors for their generous support of our online forum series. We encourage you to tweet throughout today's webinar using the hashtag HPIO forum. And then we also encourage you to connect and keep up to date with HPIO's work, either by following us on Twitter or LinkedIn and making sure that you are signed up for HPIO's mailing list to receive our publications and our weekly newsletter, Ohio Health Policy News, which always provides timely and important health policy information. If you have questions for presenters, please type them into the Q&A box, and we'll do our best to respond to your questions as time permits. If you would like to view subtitles for today's webinar, you can do so by clicking on the live captions icon at the bottom of your screen if you're not already viewing subtitles. Today's presentation slides and other related resources will be available on the HPIO website and can be found by clicking on the Events tab. My colleagues will also be dropping links to relevant resources and events for you in the chat box. Here are our learning objectives for today's online webinar, and I'll give you just a few seconds to review these. You will be receiving a survey after the webinar to assess how well we meet these objectives today. And with that, let's get into this afternoon's discussion. Over the past 2 years, we have seen the topic of racism and health rise to the forefront of public conversation and political discourse. Public and private leaders in Ohio have made strong commitments in favor of advancing equity and dismantling racism. And while in some communities there is steadfast commitment to acknowledge and address racism across Ohio, there are differing views and levels of understanding regarding the impacts of racism on health. However, I think we can all agree that every Ohioan should have the opportunity to achieve their full health potential. Hpio produces a health value dashboard every 2 years to track Ohio's progress towards health value, which is a composite measure of how we perform on population health and healthcare spending. In the last edition of the dashboard, Ohio ranked 47th out of 50 states and DC. In examining the data in the dashboard, which includes data broken out by race and ethnicity, income or educational attainment, as well as disability status, it was clear that Ohioans of color consistently had worse outcomes and faced multiple barriers to health where they live, work, learn, play, and age. And it is clear that in order for Ohio to become a healthy and economically vibrant state, we need to address the systemic barriers to health facing Ohioans of color. What you're going to hear from me and the rest of the speakers this afternoon is that progress is possible, and we must forge a path forward to eliminate racism and achieve equity. And with that, I'll introduce our very first speaker for this afternoon, Professor Rakaya Yerbi, who is the co-founder and executive director for the Institute for Healing, Justice, and Equity at St. Louis University, and a professor of law and member of the Center for Health Law Studies at the St. Louis University School of Law. Thank you, Professor Yerbi, for joining us this afternoon.
Thank you. Thank you for having me. I'm excited to present today. And let me see if I can get the slides to move forward. They are not working, so can you, got it.
It's a little bit of lag, but you should be able to go.
Okay, great. So thank you for having me. I want to start off with a story that talks about some of these issues, particularly in terms of housing. This is a picture from an article in The Guardian that was recently published, and it focuses on Yan Yu Lin and her 7-year-old daughter who live in a tight studio in San Francisco's Chinatown. They live in a century-old building where 60 or so residents on each floor share a bathroom. Because the bathroom in the building is so old, oftentimes the bathrooms are out of order or so rank and unhygienic that Lynn has her daughter use a plastic potty instead because it is safer. And this, we think, is just perhaps uncommon or only common in certain places. But what we see is that there are many places across the United States that lack plumbing. About 500,000 of American households lack basic indoor plumbing, with renters and people of color in some of the country's wealthiest and fastest growing cities, most likely to be living without running water or flushing toilets. While some rural and indigenous communities have never had indoor plumbing, the vast majority of unplumbed Americans are in fact in urban areas, and 1 in 3 affected households living in just 15 cities. This is connected to health because, as we see, the absence of running water, with the absence of running water, respiratory illness festers. I just want to highlight some of the numbers, and I will come back to this later to talk about how it impacts different groups, including those in rural areas, on Native American lands, as well as in other areas that disproportionately impact Black Americans, but wanted to highlight the lack of plumbing and water. Particularly, we see this in substandard housing and who it tends to impact. As you can see from the picture on my left, we see Native Americans have the highest rates of inadequate plumbing, inadequate kitchen, overcrowding, and followed by, particularly in terms of inadequate plumbing, Black, but very high also inadequate kitchen for Asians and Pacific Islanders. And we can see the trend being very high in urban areas. So I wanted to highlight that just to highlight something that is important for us and we often do not think about in terms of housing disparities and how they are connected with health, and I will get back to that later. I want to highlight what I'm going to talk about today in my brief time, the social determinants of health, a model that actually tries to connect systemic discrimination and these poor health outcomes with inadequate access to appropriate housing and employment, and then provide a discussion about health justice and some additional readings. So Hopefully you are all familiar with the social determinants of health. They are social factors that are outside an individual's control that prevent them from achieving health equity, their highest level of health. This is a model that the CDC has used and is featured in Healthy People 2030, which includes various factors that impacts a person's ability to be healthy. What it doesn't show, however, is the interaction between all of these factors and what really limits people's ability to have safe housing. And so I created a model that tried to reorganize some of these social determinants of health and really highlight the ways that law and discrimination impact people's ability to have equal access to housing, which we find in a neighborhood and built environment, as well as employment. I was building on the work of some social epidemiologists and my prior work. And so when we think about this, many people's current focus is on education, economic stability, which includes employment and housing, but not really on why are there inequalities and inequities in terms of people's ability to have a living wage or to have habitable housing. And so what I am going to focus on today, to some extent, is the ways that systemic discrimination and law structure systems, particularly our housing systems, employment systems, in a way that leads to poor health outcomes for racial and ethnic minorities. Now, I do use the term systemic discrimination for a reason, because it's not just about racism. It also includes issues around sexism, ableism, and classism. But I focus on racial discrimination in this presentation just so you can get one example how it impacts people's abilities to be healthy. And so systemic discrimination refers to a complex array of social structures, interpersonal interactions, beliefs by which a dominant group categorizes people into groups and uses its dominance to disempower and devalue other groups. And as I mentioned, I'm going to focus on racial and ethnic minorities for my presentation. It is about power and does not require bad intent. So oftentimes when we talk about discrimination here in the US, particular in terms of law, we think about bad intent. We also think about it being really focused on interpersonal interactions. But it is broader than that. There are 4 different types of discrimination. I am going to focus just today on institutional and structural. And usually I put together institutional and structural together, but I want to highlight the differences today in my presentation. So when we think about structural racism, it's the way that laws are used to structure systems to advantage the dominant group and disadvantage racial and ethnic minorities. And again, it does not require bad intent. And we think about it from the legal perspective, this is often not addressed or captured in many of our laws and policies because they do not go to restructuring our systems, how people get housing, the availability of housing, and the power to make those decisions is often not addressed by our current laws and policies. So let me give you an example of how structural racism plays out. This is a picture again from another article from The Guardian, and it really focused on the failure of the US government to provide clean water to Native Americans and tribes. The US government has a haphazard approach to providing Indigenous American tribes with clean drinking water and sanitation, and it is tragically underfunded, lots of neglect. In fact, there's an estimated 1 in 10 Indigenous Americans lack access to safe tap water or basic sanitation, without which a host of health conditions, including COVID-19, diabetes, and other gastrointestinal diseases are more likely. And we see that this is an issue for tribes within the Colorado River Basin, which is located in California, Nevada, Arizona, New Mexico, Utah, and Colorado. Now, I want to highlight why this is an issue about structural racism, because it again, right, does not necessarily have to focus on bad intent, but it's the way we structure our systems. It's the US government's response to provide access to these tribes. It is part of their treaties and their responsibilities, but they have neglected it and structured it in a way that disproportionately harms Indigenous Americans. We can also see this playing out in terms of those impacted in other states. So we see here an example of Mississippi, Jackson, Mississippi, where they had storms. And so there was a lack of access to water after the storms, but not for everybody. Unfortunately, what tended to happen is that people in Black neighborhoods, particularly Jackson, Mississippi, did not have access to water, whereas the communities that were predominantly white had access. Again, policies and structuring systems in a way that disproportionately harms racial and ethnic minorities. And so one of the quotes from the story, again, coming from The Guardian, is that part of the problem is that it's everywhere, said the person working to distribute water. Usually when we have an outage, it is in one neighborhood. So people are used to running over to friends' houses or their auntie's house to take a shower or fill up some jugs. Usually you can grab your buckets and find some place to fill them. But when it's the whole city, where are the Black people supposed to go? It's not like this is everywhere. It's where the mostly Black population in Jackson lives. And so how is this connected to housing? It's not just connected to decisions about clean water, but it's also connected to residential segregation, that we see the lack of investment, the lack of support for clean water and plumbing in areas that tend to be racially segregated and tend to be predominantly Black, Latino, or be places where Native Americans live. And we see this connected to not only just the health outcomes that I mentioned, but also linked to some chronic disease outcomes, right? That residential segregation has been associated with Black people's higher rates of heart disease, stroke, and blood pressure. And I want to give you one more example that we could see in St. Louis, particularly in terms of COVID-19, that we could look at maps that highlighted residential segregation and looking at the zip codes that were predominantly African-American. We could then look at where were the highest areas of severe health-related housing violations. So again, lack of clean water, lack of plumbing, and those were also the places where we saw the highest rates of COVID-19 cases and death. And so we can see, again, a great association between residential segregation, housing violations, lack of water and plumbing, and increased rates of infection from COVID-19. Now, I want to move on to the discussion about institutional racism. And next slide, because it froze, sorry. Okay, so it doesn't seem to be going further, so I will just continue, and then hopefully you can go through the slides later. So when we talk about institutional racism, that's the ways that organizations work together to create separate and independent barriers through the neutral denial of equal treatment. that results in usually the normal operations of institutions. And so this is what we tend to think about in terms of disparate impact discrimination. And so this is traditionally captured under the law. We can see this also playing out in terms of employment and how that is linked to overall poor health outcomes. So we can see that in employment, gender disparities and depression and anxiety disorders when women earn less than their male counterparts, even though they're doing the same or more work. We also see experiencing discrimination at work has been associated with higher job stress and post-traumatic stress symptoms for African-American women, and problem drinking and substance abuse for racial and ethnic minorities and Black women, as well as, great. Okay, go back one slide, if you can. All right, well, I'll keep going. You could just leave it there. So Black women exposed to discrimination while finding a job or at work were more likely to have a very low birth weight infant, which is also linked to increased rates of infant mortality, which I know is very high in Ohio, and you see the same disparate infant mortality rates for Black women. I want to focus on one particular area that we see in terms of COVID-19. There have been more than 55 million Americans who have been labeled as essential workers. The research has shown that serving as an essential worker is strongly associated with higher risk of contracting COVID-19 and dying, in part because many of these workers do not have paid sick leave or their attendance policies that require them to go to work, even if they are sick. We see this not only amongst Blacks, who disproportionately occupy the top 9 occupations that place them at higher risk for contracting COVID-19, but we also see this in those of Asian descent. And National Nursing Union report shows that nurses of Filipino descent comprise about 32% of nursing deaths from COVID-19, even though they only account for 4% of the nursing population. Next slide. And so how is this connected to institutional racism? As I mentioned before, not all of these essential workers are covered under paid sick leave, particularly those who work in the meat and poultry processing industry. We can see how this is connected by actually also looking at the punitive attendance policies of meat and poultry processing plants. Many of those plants have attendance policies where you accrue points for missing work even if you are sick. And we can see this playing out at the JBS Greenlee, Colorado plant in Colorado, where 6 workers died and 290 were infected with COVID-19 in April 2020. 1 month after the initial outbreak, 70 were infected with COVID-19, and their attendance policies were 7.5 points before COVID-19 and 6 points during COVID-19. That means you could accrue 6 points before you were fired for missing work. One of the requirements to be able to recoup those points was requiring a doctor's note and a call into an English only attendance hotline. Again, this may seem a neutral policy, but a majority of their workers were undocumented immigrants and did not have access to a doctor and did not necessarily speak English that well. And so it could seem like a normal operation, race neutral, but it disproportionately harms the undocumented immigrants and racial and ethnic minorities working within that particular plant. The Tyson plant, so that's just JBS, the Tyson plant, and you can see information about Tyson. They did not approve prearranged absences for things such as COVID-19 testing or even experiencing symptoms of COVID-19 unless it did not affect the production of the plant. And so this is just another example of a case in meat and poultry processing plants where it may again seem like a neutral policy, employment policy, but we can see that it disproportionately harms racial and ethnic minorities. One, because they were the ones that were working on the front line. And so transferring employees from a facility that had a COVID-19 outbreak and putting those workers on the front line with those who are undocumented immigrants, racial and ethnic minorities, increased the risk of those workers getting COVID-19 and actually spreading it throughout their communities. And they failed to provide appropriate mask. Now, I just want to highlight in this particular instance, we can see how this led to overall increases in profit for Tyson. Next slide. And in the next slide, if it goes there, you can see that it actually increased not only the infection rates of the workers, it increased the infection rates of the cases throughout the United States and within counties that had meat and poultry processing plants. And that disproportionately impacted racial and ethnic minorities. And we could see that in the data where they were broken out. So with that, I might stop. You can have my slides, which includes information about additional readings and perhaps ways that we can begin to address this through health justice. But with that, I'll stop. Thank you.
Thank you, Professor Yearby, for that very informative presentation. I think we're having a little bit of trouble with advancing the slides, so you will be able to download the slides by going to Hpio and clicking on the Events tab. All of the slides will be posted there. And I think we have just a minute or two for questions. So if you have any questions, please do type them into the Q&A box and we'll take them as time permits.
Hi, Reem, it's Amy Rowling McGee. I am not seeing any questions right now, but I will keep an eye out.
All right, thanks, Amy. All right.
Excuse me, I do see a question.
Okay.
This is from Dr. Sweetland, one of our next speakers. She said, or asked, or first said, I did not know the extent to which lack of access to running water was concentrated in urban areas. What policies need to be changed to make sure everyone has access?
So one of the gaps we see in our housing policies nationally and statewide often is the lack of requirements for habitable housing and the lack of enforcement. And so one of the only laws we have, federal laws, is really around lead and the requirement for enforcement and tracking around lead, which I know in Ohio, you've had a problem actually keeping up with that, particularly in Cleveland. And so That is one example of, we do definitely need a federal level policy around the requirements for water and enforcement and support. Some places do have requirements for running water, but then what they often do is keep people out of that housing, and then that leaves them homeless because they cannot afford housing that actually has those. And so that goes back to tying it into employment and wages. But one way to enforce it in a way that doesn't disproportionately harm people is to work with the landlords to be able to get those facilities to work. And then I would say with the Native American population to actually do what we were supposed to do, which is provide them with the access to clean water.
Okay, great. Well, I think you can go ahead, Reem.
All right, thank you, Professor Yerby. And I'm gonna just wait for the slides to come up. And Professor Yerby did do a wonderful job laying out the impacts of structural and institutional racism on communities of color. And I'm going to be reinforcing the information that she shared and providing some additional context on how racism specifically directly impacts health and what we're seeing in Ohio among communities of color. So I'll just pause. Alana, hopefully you're able to pull those slides up.
Maybe you're not seeing any slides at all.
I am not seeing any slides, no.
Well,
I'll just go ahead, Amy.
I was gonna say, I do see another question. So while Alana is pulling those slides up, I'll go ahead and ask that. And the question is, how much of the water issue is aging infrastructure, for example, lead pipe? Seems similar to discussion about lead paint or asbestos. How do we address aging infrastructure?
Yes, thank you. I was typing in the answer in the chat, so
Oh.
I'm glad I'm able to answer it in person. I definitely agree. And I think that is why I suggested the need to work with communities, landlords to be able to address it, because some of the problem we see with lead paint in Ohio is that it often leads to people getting pushed out. But if we work with those landlords to be able to provide money for them to do it, and get the private sector involved, right? Because I know in Ohio, you have one of the biggest paint, I guess, companies in there. So let me switch over to infrastructure as well, right? We need to invest in our infrastructure. I know it's not just a problem within housing, it's also a problem within education. I know when I lived in Ohio, there was an issue in Chagrin Falls in their schools about problems with clean water, and they were able to invest and change their pipes. And so it just has to be an investment that we make, very focused on providing water, that as we go around and put money for inspectors to check out lead paint and asbestos, they should also be checking out, do people have access to clean water? And then we should provide money for the landlords to be able to fix the pipes or address those issues. So hopefully that begins to answer your question.
Thank you, Professor Yerby.
For some reason, I think one of the issues with everyone being logged in is that it is not giving me access to your slides. I'm going to see if I can get that to work on your end. 1 second.
Okay. Thank you, everybody, for your patience.
And I could jump in just to fill the space, and then I'm going to hop off. Unfortunately, I have another commitment. There was a question in there about, is this an example of critical race theory? So I would say no. This is more an example of trying to look at the ways that our laws and policies do not actually get to the outcomes that we are trying to achieve, and it impacts everybody. I'm focusing today just on racial and ethnic minorities, but it impacts everybody. So it impacts those who are poor whites in rural areas. It impacts those who are disabled. It impacts those who are women, who are LGBTQIA. And so it really is about the fact of looking at our laws and policies and seeing, are they providing the support needed for individuals to be healthy? And if not, what are the ways that we can change them? And what do we need to do to evaluate, to collect the information we need to be able to see if it actually leads to healthy outcomes for everybody? And so with that, I will stop.
All right, thank you, Professor Yerby. And we are just right now trying to share from my computer. All right, I hope everybody is able to see the slides now, and we're gonna just advance forward to where we need to be. All right. So as I shared, I'm going to really be highlighting and emphasizing some of what Professor Yerby had already gone into detail on, and sharing some additional context on how this impacts Ohioans of color. In the summer of 2020, Hpio released a brief that goes into detail on the relationship between racism and health, and to truly advance the shared value of ensuring that every Ohioan has the opportunity to live to their full potential. It is important to ground ourselves in a clear and firm understanding of the connections between racism and poor outcomes experienced by communities of color. With this understanding, we can begin to identify action steps that can be taken to disrupt and dismantle those connections. I'm going to preface by saying that the connections between racism and health are complex. However, the research evidence is clear that racism is a primary driver of the inequities and disparities in health that we see among communities of color. And as demonstrated in this framework, racism can impact health both directly and indirectly. Professor Yerby discussed how systemic and institutional racism can impact our systems, policies, and structures to unfairly disadvantage people of color. And as a result, Ohioans of color are more likely to experience poor access to healthcare, food deserts, and unsafe and unstable housing.
Look at this.
Alana, I think we can hear you now. And just to reiterate, all of those factors can impact health. And the impacts on the impacts of racism are pervasive, and they do diminish the potential of Ohioans of color to succeed and to thrive in our state. This figure highlights the impact on Ohioans of color if the playing field were leveled. And what we can see from this figure is that if we close the gaps in outcomes across things like food security, internet access, and housing, hundreds of thousands of Ohioans would be impacted. And there are real people behind these numbers. And what that means is that we'd have more Ohioans that have the opportunity to live a longer, healthier life than they do today if these gaps in outcomes were closed. Now, as I mentioned, racism does have direct impacts on health by increasing a person's exposure to trauma, violence, toxic stress, and stigma. To give you a clear picture of what this looks like, on the left side of your screen, you see that compared to white children, parents of Black children are 17 times more likely to report that their child was treated unfairly due to their race or ethnicity. What that means is that 1 in 10 Black children in Ohio are being treated unfairly due to their race. On the right side of your screen, it shows the extent to which Black Ohioans experience racism in a healthcare setting and in the workplace. So 1 in 11 Black Ohioans are treated worse in a healthcare setting due to their race. And even more troubling, 1 in 6 Black Ohioans feels that they are treated worse due to their race in the workplace. The next figure that I'm going to share shows how experiencing racism directly impacts health. Black adults in Ohio are more than 5.5 times more likely to report physical or emotional symptoms as a result of treatment due to race. And that translates into 1 in 5 Black adults in Ohio. Anyone who has experienced racism or other forms of discrimination can tell you that it is traumatic. And repeated experiences of racism can lead to toxic stress and result in physiological changes to the body. This includes things like overloading the body's nervous, endocrine, and immune systems. And over time, through this repeated exposure, it causes what is called a wear and tear effect on a person's body, which can contribute to poor health outcomes, including things like heart disease, stroke, and poor mental health outcomes like depression. This figure shows the various ways that experiences of racism can manifest to directly impact health. And I had shared earlier that the connections, again, between racism and health are complex. Research on experiences of adversity and trauma emphasize that stress caused by experiences of racism, particularly stress at an early age, can disrupt brain development and impact learning, memory, behavior, and emotional regulation. Research also shows that demonstrates that people who are exposed to chronic and persistent stressors, such as racism, are also more likely to engage in coping mechanisms that include behaviors that increase the risk of poor health outcomes. So things like smoking or unhealthy eating. And while there's evidence that this may have a protective effect on somebody's mental health in the short term, of course, the end result of this is higher disease prevalence, higher likelihood of living with a disability, and early death for Ohioans of color. Given this, it will come as no shock if I share that Black Ohioans in our state, on average, live 5 years less than their white peers. That 5-year gap has a significant negative impact on the families of Black Ohioans and on our broader community and state at large. So in sum, racism has both immediate and long-term negative health impacts, and it's also important to understand that these impacts persist and can carry forward across generations. This diagram that you see here, taken from our Connections Between Racism and Health brief, outlines how individuals and groups, private organizations, and state and local government leaders can take action to eliminate racism and advance equity. At each level of this framework, the ultimate goal is to eliminate racist beliefs, acts, policies, practices, and structures, including the extension of leadership and power to our communities of color. Building on Hpio's 2020 publication that I shared, The Connections Between Racism and Health, Hpio is producing a series of 3 policy fact sheets that outline evidence-informed actions that can be taken at each level of the action steps to eliminate racism and advance equity diagram that I just shared. And the fact sheets highlight real-world examples of how policymakers, private organizations, community groups, and individuals can take action. Hpio released the first fact sheet in this series in September, so just last month. And that first fact sheet focused on actions that can be taken by state and local policymakers. And the next 2 will focus on what can be done by private sector organizations and community groups and individuals. I will close out by emphasizing the key steps that can be taken to eliminate racism and advance equity shared here. And I want to highlight the first 2 action steps as foundational, which is the need to acknowledge the impacts of racism on health and to continue to grow our personal and shared understanding of what those impacts mean for Ohioans of color. We cannot deny that Ohioans of color experience large health disparities. These disparities include life expectancy, infant mortality, as Professor Yerby mentioned, heart disease, hypertension, and these disparities are not driven by genetics. Evidence demonstrates that these gaps in outcomes are driven by hundreds of years of racist policies, practices, systems, and beliefs that have unfairly disadvantaged people of color. And I want to emphasize what Professor Yerby shared earlier, which is that these policies, practices, and systems did not always evolve with bad intent. So to ensure that every Ohioan has the opportunity to reach their full potential, we do need to disrupt and dismantle the connections between racism and health. And that's why understanding the impacts of racism on health and effectively communicating on these issues is so critical to moving forward. And you'll hear more on this from our next set of speakers. So I will pause here for questions that we may have before moving on to our next speaker.
Great, thank you, Reem. Again, this is Amy Rowling McGee. I am looking through the chat box, and we heard that the Q&A box may not be working. So if you have any questions, please go ahead and type them in the chat box instead, and we'll monitor that. We have nearly 200 people on today's webinar, and looking at the registration list, it was really wonderful to see such strong interest in this topic from all areas of our health and healthcare system. We had local public health folks registered, hospital system folks, providers, and many others, and quite a few folks who are engaged in the policymaking process. We want to remind everyone that the slides are going to be posted on the events page of our website. So if you want to go back and refer to any of the information later, you can do that. And then Carrie from our team is also posting a series of other resources in the chat that you may want to take a look at. I think Reem mentioned the recent fact sheet on taking action that was geared towards state and local policymakers. And then the brief that Reem and others on our team authored last year on the connections between racism and health has also been posted in the chat. Let's see, I have a question, Reem. Is more data available on the impact of racism for older Ohioans?
Thank you for that question. There are a couple of sources from which we can get data on the experiences of racism for Ohioans specifically. And so one of the primary sources through which we might be able to get data for older Ohioans is the Behavioral Risk Factor Surveillance System survey, which is administered on an annual basis by the state under the direction of the Department of Health. A reactions to racism module was included in the last iteration of the Burfus survey. And so through that data, we might be able to break it out for older Ohioans specifically. And it's there is potential that module might be included in future years. For data on children, we get that from, there are two sources for Ohio. There's the National Survey of Children's Health, and then also the Ohio Medicaid Assessment Survey. And so those are two sources that ask about experiences of racism in children. It's parent reporting, but those are kind of the best data sources that we have for our state level data information sharing.
All right, if you have any other questions, please type them in the chat. And I'd like to also remind everyone that you go ahead and stand and stretch at this point. We're almost at the midway point of today's forum. So take this opportunity to engage your body a little bit, keep your energy level up. You're going to want to be fully awake for the next presenter. All right, well, oh wait.
I see a couple more questions.
Let's see, here's a question. Do we know if the race module will be included in the Burfus moving forward? It is powerful data.
We know that module has been proposed to be included in Burfus for the next administration of Burfus, so for 2022, and we'll know in I think a few months, a month or so, actually, if that module will actually be included. Agree, it is incredibly powerful data.
Another question, are the data sources also listed on the Hpio website?
So we do have many places on our website that provide information on data sources for not just experiences of racism, but data on disparities and inequities experienced by Ohioans of color, Ohioans with a disability, Ohioans with educational, lower levels of educational attainment, low income, and geography. And probably the best source for that is going to our health value dashboard page on our website, where we have a crosswalk of various data sources where you can break out data at the state level. Thanks, Carrie, for popping that into the chat box. So that's the best source, but I know that there was also a question about whether I can include links to the sources for racism data in the chat, and I'll do that as well.
And always feel free just to reach out to us directly too. We have a lot of knowledge about what's available and what's not available. So if you're having some trouble finding something in particular on our website, we'll at least be able to let you know whether it exists or not. Okay, well, thank you, Reem. I think now we'll move on to our next speaker. We're very pleased to have Julie Sweetland with us this afternoon. Dr. Sweetland is a sociolinguist and serves as a senior advisor at the Frameworks Institute. We heard or participated in a couple of webinars that she presented on during the summer and found the information extraordinarily useful to us. We wanted to spread the word about her research and the work of the Frameworks Institute, especially as it pertains to communicating about equity. Dr. Sweetland is a graduate of Georgetown University, and she completed her MA and her PhD in linguistics at Stanford University. Welcome, Dr. Sweetland.
Thank you so much. You left out my most important degree, which is that I grew up in Cincinnati and I am a proud graduate of Mount Healthy High School. Go Fighting Owls, but also was an early lesson in my life about the connection between health and place at the, center at the top of the town there, Mount Healthy, a refuge from cholera because people went up the hill and then they were healthy. If y'all could stop sharing the main slides, I can put mine up.
I had forgotten about that connection. That's where my parents live today, in Mount Healthy. All right, so we're going to do some switching here so that Dr. Sweetland has control of the slides.
Great.
Hopefully that'll happen here momentarily.
All right. Can you see everything? Looks good?
Looks great.
Okay, great. Well, thank you, Amy, and thanks for everyone for the opportunity to contribute to your thinking and this important work on disrupting the connection between race, racism, and health. I'm going to be sharing today from the perspective of social science and the science of communications. And I'm representing the Frameworks Institute. We're a nonprofit, action-oriented think tank focused on the power of framing to drive social change. And we're based in DC. That's where I'm logging in from today, but it is good to feel like I'm home in Ohio. I'm going to go through some of these questions. These may be questions that have been on your mind, but if there are other framing questions that come to mind as I'm presenting, please add them to the chat. Don't worry that you'll distract me. I'm hopeful that we'll have a lively discussion at the couple of moments where we can stop to discuss. So I'm going to walk through some what of our research has found about what cultural mindsets exist that get in the way of our work to eliminate racial disparities and the root causes of those disparities in systems, structures, and policies. And how do we make the work harder sometimes? What common ways of communicating and talking about racial inequity don't work as intended? They can fall flat or even backfire. And what's the fix? What tested communication strategies can we use to build more urgency and support for advancing health equity? In all of these, I'm taking a very evidence-based approach. You don't need to read all of this, but I just wanted to show some of the studies I'm going to draw on today from Frameworks. We work on a range of issues, and I'll be pulling different findings and insights from our studies on the communications aspects of tobacco-related health disparities, oral health equity, birth equity, ageism, gun violence prevention, housing and health, and environmental health. So first of all, I just want to say that we publish almost everything we do on our website. So if you're working on any of these issues and you'd like to look more deeply into the advice that we have and findings that we have, these are available to you on our website. But more importantly, I want to point out that we take on these kinds of projects because we know that the way that we talk about these issues really affects the kinds of change we can create in these core elements of our society. And so these are the types of topics I'm going to pull into this conversation about racism and health today. Now, I know that framing isn't the only thing that drives change, but it is a necessary component. So before I go any further, let me just take a minute to explain what I mean by framing, and then we'll get into some of those framing questions. So framing is the process of making choices about how to present ideas. And those choices can be pretty basic and even things we're not aware of. They include where to start, what to emphasize, how to explain the issue, what commitments do we invoke? Do we talk about this as a shared responsibility or a personal problem? Framing also involves deciding when to zip the lip, what we leave unsaid. And this work, this mindset of paying attention to framing is really important, because as frames move through society, they work as interpretive packages. They include the parts of the issue that the public and policymakers pay attention to. They offer ideas about whether or not a public response is appropriate, and they suggest directions for the collective action or inaction that shapes the issues. And so these, in sum, the way we frame our issues matters because it influences how people think, feel, and are willing to act. The words we choose can really open up people to engaging an issue or closing down dialogue or thinking. So our research shows this time and again. I'll give you an example from an experiment we did to measure the effects of 2 different ways of talking about why it's a good idea for public health departments to fund and support coaching programs that help families with issues like relationships, discipline, and the sorts of things we might talk about as positive parenting behaviors. So our experiment asked people about their attitudes towards such programs and explored whether they thought they should be a federal priority. So one set of messages was about effective parenting. This was about making parenting more effective. And another changed the frame, changed the emphasis, and had a message about how children thrive when they get the support that they need from parents and others. The results were this. So if we talked about it in terms of effective parenting, people who got that message were 6% less likely than a control group to agree that this should be a priority and that these programs were good ideas. But people that got a message about what children need became, almost 10% more likely to agree that yes, we should have these, yes, they're important, and yes, we should fund them with public dollars. So that's a 16-point swing, and just one example of how a shift in emphasis, relatively small, can lead to a big difference in how people understand, interpret, and support a particular initiative. So let's think about what happens. So it's really important for us to think about what happens when we use the phrase health equity. When it comes to talking about health equity, we have to frame strategically, because so much research shows us that people don't understand just these 2 words in the ways that we probably mean them. So I'm going to show you first how people make sense of this first word, health. Got a video, it's about maybe 75 seconds long, and it moves through, it shows you some of our research. It's small group discussions that are focus groups of professionals who are working in different social change sectors, and then individual clips from ordinary people on the streets in different locations across the US. I want you to listen for the patterns in explanation, how people make sense of the word health.
What would you say shapes how healthy or unhealthy someone is?
Their diet.
Eating the right types of foods.
Working out and making sure you're making healthier decisions while you're eating.
Diet and exercise and sleep.
I mean, it's common sense. You go to the doctor.
A lot of people put off going to the doctor.
Your company can offer you the best healthcare in the world, but if you never go to the doctor or you avoid your problems, then
I think your health-wise, it just depends how you active, eating, playing, that kind of thing.
Core values. Why are people 300 pounds?
Okay.
Because they eat stuff they shouldn't, they don't exercise. And they don't look after themselves.
Some people make their lives more difficult by the decisions that they make.
Individual choices.
Some people, I think, make their own trouble.
They should also try and help themselves too. I think they shouldn't try and play the victim card.
People have to help themselves.
Personal choice, the choices they make.
Negligence mostly.
Just not treating your body like a temple.
Some people just don't care about their health.
Health is something that you have to be accountable to yourself for.
You can lead the horse to water, but you can't make the horse drink.
Exposures to bad environments, places that some people can afford, are places that really you have to decide, your life is in danger being there sometimes. And a lot of your lower income communities are food deserts, and you don't have good full service grocery store.
All right, so that video shows, illustrates what we have consistently found in our research on how Americans think and talk about health. Overall, people have narrow, little picture understandings of what matters. People's mindsets are dominated by individualism. Partly, this means there's the assumption that people's health is largely inside them, under their own control. Whether they're healthy or ill comes down to what they do, or perhaps their individual genetic inheritances. It also applies to people's thinking about the consequences of poor health. If you get sick, that's on you, that's your individual issue, especially if it's a chronic condition, it has nothing to do with me or we. Another part of this little picture mindset is a limited sense of the factors that shape health. 2, maybe 3 things are in people's mindset. The diet, exercise, and sometimes we'll hear about substance use, smoking in particular. The story about solutions is just as simple and connected to these little picture understandings of the problem. If health happens when people make the right choices, well, then people reason the solution is to tell them what the right choices are, give people the right information. Now, we know that health education has a role to play, but for the public, this model crowds out thinking about any other types of solutions. And it ultimately saps the political will that we need for all we need to do to disrupt racism in health systems and ensure health equity. Now, you might be thinking we're in the midst of a global pandemic, which has really brought to the fore all the ways our health is interconnected, and that factors like occupation and region can shape health outcomes. So some of you might be thinking, surely this has changed. Let me show you some findings from our Culture Change Initiative, which is tracking the ways in which American thinking about social issues is and isn't changing in this unique moment of upheaval, which has included not only the COVID-19 pandemic, but also renewed and broadened demands for racial justice and sharpened and polarized political identifications. So our current research, this is just a few months ago, and we've been taking like a pulse poll, and this we'll find these findings. We're about to release these findings again. The current research finds that health individualism remains strong, showing that people even now are struggling to see how systems and places shape health. So these are findings from a forced choice question when people are asked to choose between 2 statements: health individualism and ecological system thinking. And participants overwhelmingly choose individualism, that individuals' lifestyle choices determine how healthy they are. So this is an average across all groups. And I'll note that these numbers varied slightly across groups, but health individualism we did find was dominant even for groups that tend to think more systemically on issues like the economy, education, or criminal justice. For instance, when it came to health, on this question, individualism was selected by 67% of Black Americans and 66% of younger Americans, both group age 18 to 29 and people age 30 to 44. And here are the results for that question by political identification. Health individualism was endorsed over ecological or systems thinking by 68% of Democrats, and a similar share of people who identified as political independents. So one thing I want to say is that health, when it comes to health, many people are more conservative in their thinking than they might be on other social issues. Health individualism cuts across ideology. And so we need to be very careful, very mindful of that mindset in talking about any kind of structural change, because in the end, people don't really get how structures affect health. What about the other part of that phrase when it comes to talking about equity? How do people model things then? In our interviews, one thing is that that we see that similarly, most Americans think racism happens at the individual level. It's an interpersonal dynamic in people's definition, not a structural issue. So on this issue, independents pattern more with Republicans than they did on health. But even among Democrats, 60% of Americans right now say racial discrimination is about individuals' bias and prejudice, and a smaller share, 40%, think that it's a result of laws, policies, and institutions. That is much more skewed among people who identify as Republican or as independents. And in general, when we have done more qualitative work, our research and interviews have shown from people from different racial, Americans of many backgrounds, including people from different racial and ethnic groups, we see these common, deeply held, implicit, yet incomplete and inaccurate ways of thinking about why disparities exist and what to do about them. So we see a model of cultural pathology, kind of blaming groups. I would boil this down as those people just don't have the right values. That's why they're making poor health behaviors and choices. Also an idea of separate fates, that what if the actions of one group don't affect the other. And that can be either in the decisions we make to set up conditions, or if that group is having poor health outcomes, it doesn't really matter to my group. So instead of understanding that this is an interdependent system, really, segmenting out groups in terms of how they affect each other. And then finally, even for people that don't subscribe, that don't hold a strong mental model of cultural pathology or separate fates, people can have a very fatalistic sense about how much it can change, right? That it is what it is. Racism is so pervasive in America and so deeply entwined, in our culture, that there's nothing we can do about it. So none of these ways of thinking drive us to think about how we can change structures in order to have more equitable health outcomes. Now, I've used the word equity quite a few times now. I want to just point out that, so first of all, people bring these mental models to why disparities exist, but just saying we need to, replacing that with the focus on equity might not work linguistically. I'm going to show you a insight into a focus group where we ask people about their understandings of this term.
So the first is equity. And I'm wondering if you all have heard that term before, might have some thoughts about what it might mean.
That's all, like home equity, some sort of loan.
You bought your house for, say, 200, 250, and some years later it's worth 400. That gap there is equity.
Equity in a life insurance policy, what you've built towards something, in my opinion, is equity.
Equity is kind of like basically how much leverage you have. So like you're on a business or something, how much money like your business is worth.
Are you talking about money, money equality?
And if you think of equity in relation to race, what would be your guess of what it might mean?
Like racial equality, same thing.
So is it
equity equality?
The sense that I get is that when people are saying equity, they mean something more specific than when they're saying equality, but I definitely have not seen it explained.
Providing everybody with the same opportunities to be able to be successful, no matter like what level they're on.
I have not heard it mentioned as far as people. I mean, normally you hear of equity in your home.
Especially if you're poor and if you're Black, a lot of us, we like a couple generations removed from like slavery. So a lot of us are still trying to build from that gap and trying to get to that level where we have equity and stuff to leverage.
People have been saying racial equality forever. Why is it changing to equity now? Who's saying equity?
So from this, I'd just like to point out, many folks who are working on eliminating disparities have learned the distinction between equality, which is about uniform treatment, and equity, which is about ensuring true access to resources to get to the same level as others. And while that distinction might be helpful in shaping our policies and practices, if we're going to use the term equity, we really need to explain what we mean. I think this shows clearly that the average American isn't familiar with that term. It doesn't mean they disagree with it. It just means they haven't heard it yet, and we need to be clear about it. So the misunderstandings of these two constituent parts, health and equity, help explain why when we just rally behind the banner of health, those messages don't always get as much attention and support as we might think. In 2014, we tested different ways of framing environmental health. And the emphasis on protecting people's health and public health had no effect. We actually found that framing the issue in terms of fairness across places, like a zip code argument, worked much better. A 2017 experiment, we found that we tested different ways of talking about oral health disparities. And when we talked about the issue of economic impact, missed days of work or productivity had mixed effect. When we talked about targeted universalism or fairness, kind of a a customized or tailored approach to fairness, that worked much better. In the last couple of years, we've been leading a project on tobacco-related health disparities, and we found that emphasizing the negative health impacts had no effect on people's willingness to support equity-focused tobacco policies, like using tobacco taxes and reinvesting that money into affected communities, or changing retailer density so that there weren't so many, so that Black and Latino neighborhoods aren't saturated with tobacco retailers. So talking about the negative health impacts had no effect on that kind of policy thinking, but framing the issue in terms of justice did drive those kinds of more equitable, anti-racist policies. And just recently, we did an experiment testing different ways of framing gun violence prevention in a heavily Republican Midwest state, not Ohio. And messages about potential health benefits had no effect, and messages about negative health impacts actually reduced support for policy. And among Republicans, they really rejected those negative health, the kind of number of deaths to gun violence. They felt they were being emotionally manipulated to try to take a position that they didn't agree with. However, we could move the issue among Republicans, among everyone, by just pointing out to everyone our shared belief that in a democracy, our laws should reflect the priorities of voters and the will of the people. And actually, most people are concerned about the number, about the level of gun violence in our communities. And so we need some sort of response from at the legal level. That did move people to really want to endorse sensible approaches to reducing gun violence. So we can get people to advance and support and get behind health equity issues, even, especially policies that are designed to really target and root out racial disparities and racist thinking in the health system. But talking about it in terms of health might not get us there. So in general, the American thinking on health is individualism. And so you can't assume that framing an issue in terms of health will work. People might just think, well, those people should make better decisions. Similarly, because most people don't understand how systems and structures are creating and perpetuating racial disparities, you can't assume that just pointing out racial disparities will work. People are all too ready to fill in a story that's about cultural pathology into that number story. We can't assume that people know what equity means. So these are places that people start. It doesn't have to be where people end up. Framing can help, and I'm going to get to that in just a moment. But I wanted to pause before I go any further and just see if comments or questions had come into the chat, or if people want to add some now. Amy or Reem, have anyone? What's cooking in the chat?
Yes, we did have a question in the chat, and the question was, I'm curious if this survey asked the respondents to self-report how they see their own health, mostly healthy, mostly unhealthy, etc. And does the self-perception of health impact opinions or attitudes about individualism or not? So I think this was referring to your slides earlier on in your presentation.
Yeah, no, that's a good question. I don't believe that this particular survey asks that. We've got a lot that we're going for in that project, so I don't know that we had room to fit that in. I do know that on some of our more specific health-focused studies that I mentioned, we have asked. So for instance, in our work on tobacco disparities, we ask if people are current or former smokers or never smoked and how they feel that's affected their health. On oral health, we ask people about how they feel about that. And individualism still comes through. I think I personally have been surprised the extent to which people will blame themselves for health conditions that, if you take a step back, have many factors contributing to them, not only personal behavior. So I wonder if that's the question behind the question. I also see here a question about targeted universalism, how this is defined. That's the idea that all humans, right, need certain things. For instance, we all benefit from safe, stable, supportive relationships in early childhood. There may be some groups where that process is disrupted more than others, right? And so we need to look to those. So children whose mothers have depression, or children in families where where there's substance abuse or other mental health issues, right? And so we'd want to zero in on that population and figure out what's needed to get that universal need to that targeted group. And I have another example of what this means, how we use that in plain everyday language, a couple slides down, so stay tuned. All right, I'm going to move on for now. Keep the questions coming. We'll have some more time at the end to chat. So the mindsets that exist aren't hospitable to our efforts to disconnect race and racism from health outcomes. But we can shift mindsets. We have strategies that are available, evidence-based strategies for changing the conversation. I'm going to go through these 4 strategies for reframing a communication in ways that get people closer to health equity. First, if you are leaving room for people to assume, to fill in individualism or cultural pathology, the fix for that is to explicitly attribute responsibility to systems, policies, and structures, and show how, well, to say that. And I'll show you some plain language ways to say that. Second is, if you're beginning with numbers of the problem about racial disparities or textbook definitions of health equity, it's more effective to lead with a plain language expression of the value at stake, like justice or fairness. If your communication is all about who experiences disparities rather than how they come to be and how to end them, then it's better to center explanation and to let people see how, so that we can see where it can be, where we can make a difference at the level of policy and change. And then finally, if your communication takes a tone that suggests that this message is only for people who already agree with you, or that it's an argument, you're likely to be silencing many people who agree with you. They'll want to stay away from that conversation. Instead, we can take a reasonable tone that positions, well, a tone that positions us as a reasonable partner in a conversation that we can't avoid, that's really important, but is going to be inclusive. So I'll walk through these, starting with the attribution of responsibility. One thing we can do to make sure that our communication doesn't leave room for people to assume that the fault for a health problem lies with the people experiencing it is to point explicitly to the systemic, structural, or policy level factors that help explain it. And that doesn't mean we have to turn into policy wonks in places where that conversation might not be appropriate or welcome. We can simply zoom out from the person or people experiencing the problem. Think about widening the shot to show the other places in our environments that play a role in shaping a health behavior. So instead of only pointing out, making the story about the prevalence, for instance, of menthol cigarette use among people of color or among young people of color, instead we can zoom out from that and talk about what we can do to interrupt that pattern, right? We can talk about engaging our health system and how pediatricians can make a big difference in youth smoking when they're trained to do motivational interviews with adolescents about the substances that they're using. Or we can bring in the importance of school-based health courses in equipping students with healthy coping skills for stress, and also explaining how important it is that how substance use can shape the developing brain and body. We can point out the environments that kids are walking through as they go to school every day, and that we can have regulations that restrict the sale of commercial tobacco near schools, meaning those kids see fewer ads and are less likely to try harmful and addictive products. And we can really talk about our overall access to healthcare and how that tobacco use is less likely to become a serious problem when everyone has access to behavioral health services to reduce their stress or manage their stress, and also access to effective nicotine dependence programs. So it doesn't need to be, it can be very relatable and easy to understand, but widening out from the individual behavior. Sometimes our communications do blame the people that are involved, even in subtle ways. So here's a communication that I saw recently. Every year, roughly 3,600 babies in the US die suddenly for unknown reasons. Researchers estimate that if expectant moms would just quit smoking, we could prevent 800 of those deaths. So this is clearly placing the entire problem on the mothers and their decision to smoke or not to smoke. Whereas I just showed you many of the factors that condition that decision. Sometimes people say this is a too extreme example. No one would ever say that, but I took this from a major newspaper within the last 2 years. So don't say this, but what can you say instead? You can attribute to systems, right? Point to one of those kinds of factors that I just illustrated. So researchers estimated that if we just connected expecting families to treatment for nicotine dependency, we could prevent 800 infant deaths a year, right? Get the patches to the expectant families, right? Not just the mom, but the people around her. So widening that shot. Sometimes it's more common that we just leave out who or what is responsible. So with the best of intentions, just saying something like this, saying what is too many women are suffering from pregnancy complications that lead to serious injury and death. That leaves open too much room for individualism and cultural pathology explanations to get filled in. People will ask why, and the first thing that comes to mind are those dominant mental models. We can head that off by shifting the emphasis. So instead of women suffering, we can talk about who's got the problem here. Well, the US is failing to manage pregnancy complications that lead to serious injury and death. And the next few examples down, I'll show you how to connect that to race specifically. But if we know that any communication, people are going to fill in individualism and cultural pathology, we want to really push people to understand the systems. So framing moves in mind. We want to make sure that we're not just letting information about disparities drop from the sky. We want to make sure that we've got a concrete subject and an active verb, that the driver, right, the agent in that sentence, our system structures, ideologies, things like that. And all of this is attributing responsibility, not blame. We're not wagging our finger at folks, but rather widening the lens. Second framing fix. Lead with the aspiration, not the problem. Often we start with a statement of a social problem that we want others to take part in addressing. Like I just showed you, too many women are suffering from maternal complications. That sometimes can lead people to want to avoid the issue rather than approach it. If you've ever been this lady on the street corner trying to run away from the person asking, hey, you have a second to engage in this problem that we've been wrestling with for decades, centuries, or since the dawn of civilization. When we lead with a big major problem, that can lead people to a sense of overwhelm, apathy, and avoidance. So I'm not suggesting that we not talk about racism. In fact, we should absolutely talk about racism, but can we lead with something that's more aspirational and lead people to that conversation rather than the problem being the first thing out of our mouths? So we can lead with one of these flavors of fairness. These are three versions of the idea of justice or fairness that our research shows does engage people. They resonate. People say, yes, I agree with that across the political spectrum. And if you start with a statement like this, you're getting people to say, yeah, that is something I want to support and learn and engage with, rather than, oh my gosh, I don't want to have that conversation. So one is this targeted or tailored fairness. We need to ensure that everyone has access to what they need to support good health. That means recognizing and accommodating specific needs, because health is not one size fits all. This kind of can really, if there's a particular group that needs a particular intervention, this can be really helpful. Or the fairness across places flavor of this. Everyone should have an equitable opportunity to be as healthy as possible, no matter where they live, work, or play. To get to that, we need to address social problems, unfair practices, and unjust conditions that can undermine or weaken the health of specific groups of Americans. And you could make that more specific if you're talking about Black Ohioans or Latino Ohioans or Ohioans of color. You could say that, but I wanted to leave this kind of unspecified because there are many types of racial and ethnic inequities. And then the final version, this is a version of social justice. I wouldn't use those two words. They're too much of a partisan cue, but the concept of social justice, that we as a just society make sure that everyone is equally protected, fairly treated, not singled out, able to participate fully, right? That it's on us to provide a just society. That idea can resonate broadly. So here's a version of that. A just society ensures that no person, regardless of the color of their skin or who they love, is exposed again and again to things we know are harmful. To live up to the ideal of justice for all, we must tackle unhealthy conditions and barriers to good health that affect some communities more than others. So I want to recommend these flavors of fairness to you as kind of your first sentence in your annual report or on the webpage explainer that you have on a particular health disparity. Lead with the aspiration, not the problem. So here's what that looks like in a communication. On the left here, I have a communication from a public health agency that really is trying to hone in and zero in on the issue of racial disparities as it relates to tobacco, but it does it by emphasizing on the problem and the unequal outcomes. I'm going to give you just a moment to read that and take a breath and a drink of water. Okay, so in this communication, the idea that this communication is defining the problem as the destructive health effects of tobacco in Black communities, and it adds point after point to try to make the point. Our research has showed that this just doesn't work. It's not new news. For one thing, the tobacco control movement has already been effective in making Americans believe and know that tobacco harms health. So by focusing only on the negative health impacts for this particular community, the public response is one of cultural pathology or solutions awareness. Like, didn't they get the memo? We need to make sure they know, or they should know, and they're still making the wrong choice. So on the right, here's how we can make the argument for targeted interventions and focus on the effects of unequitable, unequal obstacles on this issue by stating the principle at stake that a just society has a responsibility to ensure equal protection and remove unfair obstacles for all. So this starts out with that explicit statement of what justice means in this context. And then it points to an obstacle to that ideal, to that value, targeted advertising. It's clear that this unfair practice leads to harm, and then it calls on us as a society to do something about it. So you can see here that my reframe doesn't just drop in the word justice or equity or add a new title to the same old content. It is explaining and lifting up this aspiration of justice, but it's also shifting the emphasis from who is affected to who is responsible. It's reframing from unequal outcomes to unfair practices, which is where people see a need for action. All right, so I'm going to continue that theme a little bit with thinking about explaining the how it happens. We believe that, oops, right there, we never want to have this problem where we have pointed out a bunch of predictors or risk factors and a lot of disparate health outcomes, and we've left the how in the center. How we want to leave out step 2 of how that happens.
Dr. Sweetland, it seems like your screen is freezing, so we're just going to take a second to regroup.
Hello.
All right. Are you able to reshare your slides again?
I think so, but when did I cut out?
Just a few seconds ago.
Okay, so we've got the cartoon. We're through that.
Yeah.
I think you are at the cartoon, yes.
Okay. All right, let's make sure we explain. You can see the slides?
Yes.
That was very strange. Okay. All right. So what do I mean by explanation? Often we think we're explaining when really we are just defining. This is a definition or an assertion, not an explanation. The negative effects of concentrated poverty are especially likely to affect Black Americans and Latinos, who are more likely to live in low-income neighborhoods. This is a result of legal and social discrimination against people of color, which stems from the legacy or history of enforced segregation and continues to affect residential patterns to this day. So this is true. The information Dr. Yerby showed, that Reem just shared, shows how true it is. And so this is a strong social analysis. I like to suggest that this sort of communication needs a stronger communications analysis. It needs to be more explicit in step 2 by saying how. What is it that connects the problem, the population, and the problem? If we don't fill in that link, people make it easy for people to assume that the population is the problem. So here's the alternative. Banks are more likely to give subprime loans to Black and Latino applicants than to whites with the same financial history. Higher interest rates make it harder for owners to afford improvements and increase the risk of foreclosures. That lowers nearby property values and makes it hard to sell. Racism in banking helps to explain why people of color are more likely than whites to live in distressed neighborhoods. So when we tested this difference, here's what we saw. We wanted to see what made a difference, this assertion versus the explanation. Did it make a difference between people understanding it's a systemic issue? Would it be a response, a public response make a difference? Is this a policy issue? And do you agree with our claim that discrimination helps to explain racial disparities? What we found is if we just defined the issue, if we just said, hey, this is about racism, that had no statistically significant effects. But if we added the explanation, we saw that that we can get multiple, pretty significant changes in how people do. And these results are with Republicans only. So this shows just how powerful this can be. So in general, explain more, list less, use explanatory chains that fit together, like dominoes, right? Just dominoes that are just placed, close enough to each touch each other. You want the links to be really strong. You want to lay out your cause and effect sequences and use a tight logical flow. When you do take the time to do this, you can double your level of support as compared to mere description. I'm going to go, well, you know what? I am not. So here's what that might look like in communications. So remember this sentence: in the US, too many women are suffering from pregnancy complications that lead to serious injury and death. The US currently ranks lower than all other developed countries when it comes to maternal death ratios, and some women are at more risk than others. Statistics suggest that race and racism play a role. Black women are 3 to 4 times more likely to die from pregnancy-related causes, even when we control for risk factors like smoking, obesity, or attending prenatal care. So that is, again, trying to say it's for this population. I've eliminated all other possibilities for you. So obviously you need to understand that this is race. That type of strategy does not get broad support. We can get that broad support, again, by explaining rather than asserting. So here's the same issue I gave. So we're failing to manage pregnancy complications. And now I'm going to go deep into one explanation, not the only explanation, but I'm going to help walk people through a chain that shows me why racism is at play. How is racism affecting outcomes? So one reason is implicit bias. Like all of us, health professionals absorb stereotypes that affect their decisions. The stereotype of the strong Black woman can lead doctors to minimize Black mothers' concerns and miss opportunities to address problems before they pose a danger. Implicit bias helps to explain why Black women are 3 to 4 times more likely to die from pregnancy-related causes than women from other groups. Now, again, I know implicit bias is not the only reason that this disparity exists, but our research suggests that it's smarter and better to explain one thing well than it is to give a laundry list of lots of things. Again, because when people understand what affects what to what end, they can see a place to intervene and therefore want to help solve the problem. They also have an easier time acknowledging the problem when it's explained in this way. So overall, if you've misplaced your responsibility by blaming folks inadvertently, or missing the responsibility altogether because it drops from the sky, this explanation can be an antidote to that. You can include a causal pathway, and here I've laid out kind of some generic causal pathways that you can tailor to specific issues. So some Americans are protected from health harms, others aren't. That you could apply that to, say, secondhand smoke, or environmental toxins, right? That would be one sort of example for that. You can talk about the role of economic and racial inequality and injustice increasing stress, which can trigger and compound health problems. So that's a place to talk about the experience of everyday racism and interpersonal racism, but also the effects of economic injustice and financial instability. You can talk about how unjust and unfair practices have caused harm in the past, but make sure you show how they continue today. Don't just go to the legacy of segregation, right? Show how the housing policy, right, is unfair now and in this time as well. You can talk about implicit bias or bias practices that shape the experiences of some groups of color in particular ways. That's often different group by group, but it's an important causal pathway that is keeping racism and racist outcomes in place. And then how industries, soda industry, snack food industry, tobacco industry, they saturate neighborhoods of color with marketing for harmful products. I don't want to say these are all of the causal pathways, but these are some go-to ones that you can see how to fit that into your explanation. And explanations don't have to be lengthy lectures. I've given some meaty, examples to help you see the point, but this one I think has 40 words and it packs a lot in here. Millions are exposed to secondhand smoke and some can't do anything about it. We can see that this is a child and a child of color. And so it shows a causal pathway. And then it gets a little deeper. Even if you don't smoke, you can still be exposed to secondhand smoke in your home through vents, doors, and windows. So showing how that happens. So talk to your landlord about making your building entirely smoke-free. So overall, never mention an association without an explanation. This comes to mind because I'm here in DC where we have taxation without representation. But remember, if you're bringing up a population and a problem, you've got to show the how. Don't just name drop the past. It's important to acknowledge and bring history into the conversation, but show how it's showing up today by giving contemporary examples of unfair or unjust practices. And in general, like the great line from the musical Hamilton, list less, explain more. Finally, please position yourself as a reasonable partner in an important and inclusive conversation. Adopt a stance that suggests that you consider your message to be for everyone, not just the people who already share your point of view, or it's not just for those people who are opposing it. You want to signal that you're inviting people to engage in a discussion, not a debate. Our public debates about complex social issues are increasingly polarized along ideological and political lines. And some communication strategists recommend using that, right? Use the strongest rhetoric possible to energize the base. I couldn't disagree more. When it comes to long-standing social issues, it's really important that we take care in expressing or evoking emotion. If our messages could easily end in an exclamation point, or if they could be heard that way, they're more likely to turn people away than to turn them into supporters. And so it's important to remember that, especially when we are in unfriendly or conservative contexts, most quiet supporters out there don't need to be persuaded of your point of view. Rather, they need to be persuaded that it's okay to participate, show up, and talk about the fact that they support. So we want to make sure that we're leaving space for all people to participate in a conversation. If we don't, we only get the loud people participate in the conversation. We need to leave room for the quiet supporters to speak up. So news media depends on the argument culture. The rest of us don't have to. Again, we can set a table that is about an inclusive conversation. To do that, one thing we can do is avoid partisan language. We don't want to activate my side bias. We want to keep dialogue and learning open. And instead of giving a sense that, we're indignant about this and people who don't agree with us don't care, we can instead focus on explanation and mainstream the idea that most of us are deeply concerned and we can take action. I'm going to skip past a little bit of this just to leave you with
article number 3.
A sense of what this tone can do. When we ran an experiment asking people to respond to a reasonable tone and think about using it at a Thanksgiving dinner with pro-gun people to argue for gun control, here's the kinds of conversations people had about how they responded to that kind of tone.
Article number 3 was more middle ground, a softer approach.
It was a little softer, more inviting for a conversation starter.
Article 3 was, it has an open demeanor, a more approachable dialogue to reasonable people.
Regardless of what you think about it, you have to admit that there's an issue.
The gun violence is an issue, and that's just a fact. It's not an opinion.
It starts off with something that we can agree on, that gun violence is a problem. So, and it doesn't really matter which side of the political scale that you're on. I don't think anybody disagrees with that.
I think regardless of where you stand on gun ownership, I think we can all say that gun violence destroys thousands of lives.
Okay, so you can see that the response to that is people want to engage in the conversation, not turn away from it. I think we have a similar issue when it comes to talking about racism. People often want to avoid that conversation. Our tone can make all the difference. All of these are relatively small changes, but as James Baldwin poetically put it, about 50 years ago, the world changes according to the way people see it. And if you can alter even by a millimeter the way people look at reality, then you can change the world. Framing can often feel like altering your message by a millimeter, but that can have a really big difference in the way people react. Amy, I don't know if we have time for a couple questions or if we want to move on.
I think we have time for a quick one. So I'm going to take the liberty of picking. Somebody asked, how recently was the framing research that you cited today done?
Well, depends on which piece I cited. So today I brought up studies done as far back as 2014 and some that are still on, we're still active live research right now, kind of fresh findings. So I would say all within the last, 7 weeks to 7 years.
Great. Thank you. Well, I remember one of the things that really stuck with me from listening to the other webinars that you presented on was the idea of you not being anti-data. You stressed that with us. Yeah. But starting with aspiration, then explanation, and then the data. So, we have definitely violated that rule many times here at HPIO in the past, where we just launch right into the data. You've reshaped our thinking related to that. And now it's like a mantra here at HPIO that we're like aspiration, explanation, data. So thank you so much for the impact that you've had on our work. We hope others have taken away a few things. I find myself looking back at your past slides and information as a reference. So we very much appreciate your being with us today.
Well, that's good to know. I will take that back to the Framing Mothership. We always love to hear about impact as nonprofit folks. But also thank you for the opportunity to share the thinking and for the great work you're doing. It's been a great panel so far. Thanks so much.
All right, thank you. And as you all know, we've had some technical difficulties this afternoon. We hope you can stay with us just about 10 minutes after 3 because we are running just a bit behind and we want to allow Dr. Dean his time. Dr. Dean is our next speaker, and I believe we're going to be, hello, Dr. Dean.
Hello.
We're going to be controlling his slides for him, I believe, so we need to pull those up. Dr. Dean is an assistant professor in the Black Studies program at Denison University. He has his PhD and his master's degree in religion, both from Vanderbilt University. He also notably is on the Columbus Dispatch's editorial board, where he hosts or co-hosts a podcast that he may say a few more words about today. So Dr. Dean, without further ado, we'll let you move forward with your presentation.
Excellent. Thank you very much. I'm glad to be here. Good to see everyone. I hope you all can hear me and see me. Let me know if I freeze or anything like that. I'm going to dive right into it. I do have a class that I have to get to. So, as much as I want to,
we're so sorry about that, Dr. Dean.
No problem. You know, you'll be part of my class today. I want to start off with a quote from W. Du Bois. Souls of Black folk. I hope you all are familiar with this text, familiar with this great philosophical thinker. I teach it in my Intro to Black Studies course. One of the reasons why I teach it, because I'll read this quote from you to you. And you go to the next slide. Herein lie buried many things which, if read with patience, may show the strange meaning of being Black here in the dawning of the 20th century. This meaning is not without interest to you, gentle reader, but the problem of the 20th century is the problem of the color line. He continues to say, between me and the other world, there is an ever and unasked question, unasked by some through feelings of delicacy, by others through the difficulty of rightly framing it, all nevertheless flutter around it. They approach me in a half hesitant sort of way, eye me curiously or compassionately, and then instead of saying directly, how does it feel to be a problem? They say, I know an excellent colored man in my town, or I fought at Mechanicsville, or do not these Southern outrages make your blood boil? At these I smile, or am interested, or reduce the boiling to a simmer at the occasion may require. To the real question, how does it feel to be a problem? I answer seldom a word. I think about that and I posit on Du Bois quite daily in my everyday teaching and my engagement, particularly with COVID, the pandemic, Black Lives Matter, so much is happening in our world. And then just recently, we're a year later after after the governor of Ohio and the mayor said that racism is a public health crisis. We've been saying that for a long time. However, what I want to illustrate, there's something else that's going on in this conversation as I listen to everyone's presentation, just listening to everything. It's fascinating, they're amazing, they're phenomenal. There's one key factor that I kept hearing over and over again, making very clear distinctions between a case system that happens in our country that is happening here in Ohio, the haves and the have-nots, as well as those who are Black and those who are poor. So when I think about that, and I'm thinking about where we are this year later, after COVID, we're still dealing with COVID in the pandemic, trying to come out of it, dealing with race, dealing with the racism as a public health crisis. I emphasize public health. Public health. And I start thinking about, what about private health? Have we considered private health, the private sector? So much emphasis is on the public that we continue to disregard those who participate and have actual resources and access to the private. I myself have access to the private. Does not my private information get reported to the state as part of the public? Or is there a general presumption because I am a Black man that my racial identity becomes conflated in the entire into the entire configuration of what it means to be Black in Columbus. So I'm hearing these presentations, I'm hearing everyone talk about, it's a Black community. And my question comes, which Black community are you referring to? Which Black community are you talking about? We're not all in the same Black community. There's some of us who live downtown, some of us live in East Columbus, some of us live in Hilliard, some live all these other different parts of Columbus. Which Black community are you referring to, or are you conflating the Black community to mean one monolithic Black community? So I'm thinking about that. So I'm thinking about what it means to be Black, what does it mean to be Black, and parsing out our identities, conflating Blackness into fitting these types of norms or these ideologies they have around norms around race. So these are my questions I'm posing to you all to think about. Protest, marches, arrest, activism, day-to-day living. These significantly impact very particular Black people in very particular situations and experiences and areas very differently and very uniquely. Health, mental health, physical, emotional, well-being of people of color. I've been thinking about that. I recently went to the doctor. My doctor said, you are a Black man at a certain age, you should start thinking about your health as far as like high blood pressure, heart disease. So I'm thinking to myself, okay, well, I've been coming to the doctor for quite a while. I don't have any known illnesses or anything that's wrong. But because your presumption is that I'm a Black man of a certain age, that I need to start thinking about these things, because historically, or what science says is that because I'm a Black man of a certain age, that these are the factors that are going to impact me significantly. So the doctor proceeds to ask me a question: do you have a history of heart disease in your family? I'm thinking really hard and long. And I say, no. I'm thinking about all the people in my family, my aunts, my uncles, my brothers, my sister, my cousins, and everyone. And I'm like, well, I don't know of anyone who's passed from heart disease. I've been to a couple of funerals, but none for heart disease. Are you sure? The doctor persists. So I start to really think, am I missing someone? Does he know something I don't know? So then, after the doctor, I called my family because I said, maybe I am missing someone. No one in the family can ever, provide verification that someone in our family has died from a heart disease illness. So it's about to make me think again, the presumption of what it means to be Black. The presumption of what it means to be Black and how we hold that tension. So it goes back to my very first reading of what I'm talking about, W. Du Bois, when it says, how does it feel to be a problem? Next slide, please. Anxiety, race, and health. So as I mentioned, last year, Black people who were protesting, not only just during the COVID, but also for George Floyd, Breonna Taylor, and the many lives of people who are dying throughout the country, I started to think about communities that were under extreme pressures of anxiety, extreme pressures of health and the race, and how all of those are intertwined. I started thinking about the ways I teach in my classroom, how I teach that trauma, and trauma lives in the body. And I wonder how those persons who are on the front lines, who are marching, who are protesting, those who are activists, how are they attending to their self-care? How are they attending to their anxiety? How are they attending to their own health issues that may arise from being harassed, being arrested, being on the ones protesting and marching, chanting, the anxiety of living and the threat of being arrested. What does that mean on a day-to-day basis, not to just live with that in that particular moment, but as I said earlier, the trauma that lives in the body that continues to be exacerbated by the societal forms and environmental forms that continue to help proliferate the way we experience health disease, the way we experience high blood pressure, the way we experience diabetes, the way we experience obesity. Next slide, please. With this in mind, I started to think about the mental health of what it means every day to wake up, knowing the anxiety that you have to deal with. And I think people, and what we're going to shape with all of the speakers who spoke before about the health and the social implications, environmental implications, how that impacts the mental health disparities of people of color. So as you will see, that African Americans are more likely to experience a mental disorder than their white counterparts, but are less likely to receive treatment. Well, why? Because cultural biases against mental health professions and healthcare professionals in general prevent many African Americans from accessing care due to the prior experiences with historical misdiagnoses, inadequate treatment, and a lack of cultural understanding. Only 2% of psychiatrists, 2% of psychologists, and 4% of social workers in the US are African American. In Ohio, it is imperative to be aware of mental health disparities, especially since 15% of the African American population is uninsured, while 40% live in poverty. We'll get to poverty, but I want to just cultivate this so we understand cultural biases and why it's important for sometimes Black or African Americans to seek out those who look like them for treatment and for care, psychiatrists or sociologists or social worker. Because it's very easy to tell someone to get over something or how are they dealing with something. And I have to list everything that bothers me or that exacerbates how I'm feeling. There are some things that something can be explained, but there's some things that happen when someone who is receiving care or treatment from someone who understands the cultural nuances of what it means to be Black. And sometimes I have to explain that to my students sometimes. And when I do that explanation, I say, you know, when I wake up in the morning, I have to prepare myself mentally for my day because I don't drive around the corner because I don't live in Denison where I teach in Granville. I have to drive from Columbus to Granville, which is about a 30-minute drive. In that 30-minute drive, I have to anticipate the way that I drive, which roads I take, and will I encounter a police officer during that drive? So the anxiety is already there for me in the background. The drive itself creates an anxiety. Am I doing the speed limit? Making sure that I'm obeying the law, making sure I have all these things and precautions into place as I do this drive every day, back and forth. And you know that road, if you're not familiar with that road going to Denison or going to that drive toward Newark. But there's also tension that I hold. Now that I'm very conscious of and aware. There's a tension that I hold in my neck. There's a tension that I hold in my mouth when I grit and I grind my teeth. There's a tension that I hold in my stomach. And I try to do deep breath exercises to release that, to let it go, to not deal with that. That's just one aspect of one part of my day. Not the other microaggressions that I have to face while I'm also, experiencing driving, but also when I go to the grocery store, when I go to any places, my daily travels. There are other microaggressions that happen. Having a psychiatrist or sociologist or social worker who can understand those type of nuances, can understand those type of things when I say, you know what? These are things that we know that you are experiencing on a day-to-day basis. Someone of color, especially a Black man, dealing with these things. And I'll talk about more about that. But let's move on to the next slide. I know we don't have much more time, but we talk about poverty. In 2018, Policy Matters Ohio did a study, and according to the study, over 700,000 Ohioans live in deep poverty, meaning they have incomes under half of the federal poverty level. Black Ohioans are 2.6 times more likely to live in poverty than white residents. And they're 30% more likely to die from heart disease than white residents. Ohio ranks 47th in the country for how poorly the health of lower income residents compared to higher income Ohioans. And policymakers Matters also noted that there are 3 changes that can happen at the state level, including investing in education, increasing the minimum wage, well, as so many Americans protest the raising of minimum wage, and access to public benefits and target state investment in those areas of concentrated poverty. Will that eradicate the experience of racism that Black people experience? No. No. Just because we erase markers or we implement systems to help Black people or people who are disadvantaged and marginalized, it does not eradicate the experience that people of color have on a day-to-day basis, the biases, the very note that I read in the very beginning. The problem of the 20th century, what W. Du Bois was arguing, is the color line. We're well into the 21st century and we're still dealing with the color line. The second is that, how does it feel to be a problem? How does it feel to be a problem? The pandemic exacerbated and gave us a very grand landscape into the lives of Black and African Americans in our world. They're suffering. They are the largest impacted group. Something that we've been saying Scientists have been saying, healthcare professionals have been saying, you all have been saying this. I've read your data. I looked through your data. I poured through your data. This is nothing new. Racism has always been a contributing factor to the health crises in African-American communities, but there has nothing been done. So we pour more into education. We pour more into increasing the minimum wage. We pour more into public benefits. Does that eradicate or change the situation? Next slide, please. So Ohio's poor health rate relates to part of the divide between lower and upper income Ohioans, which I said, it's all about class, the caste system. In its disparity index, the 2018 Commonwealth Scorecard on State Health System Performance ranked Ohio 47th in the nation of how poorly the health of our lower income residents compared to that of our higher income residents. Low income Ohioans are far more likely to report having fair or poor health, losing teeth, smoking, and being obese than their wealthier counterparts in the state. Access to healthcare for low-income households is an important piece of solving the health divide puzzle, but it's not the whole picture. Clearly, it is not the whole picture. Again, socioeconomical factors play a huge part. Another way that we took about, and I want you all to look at here, that the class is actually missing in this whole data, and something that we've all been missing, which is the middle class. And there are middle class Blacks who are doing extremely well. And I sometimes wonder why we do not focus on those who, the middle class Blacks, what has happened in their communities, and those who move from poor or impoverished communities into middle class capabilities. Do we study the transition for those who transition from poverty into middle class? What does that mean when you transition from someone who has these poor health conditions, all these other things, and poor, low income? All of a sudden now you move, going back to school, you're able to get an education, you have you have a master's degree or a bachelor's degree, you earn more money. Does that change just because your socioeconomic position has changed? Does that change how you experience racism on a day-to-day basis? And I think that's something we still need to explore. Next slide, please. So as we see, the housing in Columbus, Ohio, I know Shayla Favor, the councilwoman, has been doing a lot of work in community to ensure that people who are being moved out of their communities have access to low-income housing, or they remain in their communities. So there's been work that's been happening at the city council level to help ensure that people who are suffering or maybe losing their homes are still provided with low-income housing. Next slide, please. So what are some of the things that impact in those who of us? It's just stress. Stress is a huge side effect of poverty. Numerous researchers have found an association between low socioeconomic status, high stress, and poor health. There are two kinds of stress: exposure to life events that require adaptation, divorce, job loss, and a state occurring when demands appear to exceed a person's abilities to cope with those demands. Stress. As I just gave you, illustrating a huge example, the stress that I have to deal with on a day-to-day basis. My stresses are totally different from my white counterparts who have other stressors probably, but mine are more exacerbated because of my race. I have to take that into consideration. We talk about life events that happen. Black Lives Matter is a huge event that has taken over, that has helped to exacerbate how we look and assess life and look at Black people the way they are mistreated. We look at the healthcare system as we talk about, especially during COVID. How has that continued to be persisted even beyond slavery? We see how racism in the healthcare industry has continued to access and continue to help people remain into impoverished communities, but more so how that stress to continue to fight and to recounter the racism that they occur. And the wage gap, we talk about that. We talk about housing, the access of not having housing, so many other social factors that create stressors in other people's lives. So people at low income levels are more likely to encounter these kinds of negative events and encounter them more often. They also feel less control over the outcome when they do occur and have fewer social and psychological resources to cope with them. So one of the things that we just, I've always taught my children, my children, Lord, there I go, my students. The Black church. The Black church has become an essential community institution that has been one of those forefront and foregrounding institutions that have helped Black people to deal with their stresses on a day-to-day basis. But the Black church cannot be the be-all and end-all. There needs to be more resources poured into communities, particularly psychological, sociological, and psychological, to help people to deal with those stresses and how to move beyond those stresses in their lives. So wealthier people, on the other hand, have greater opportunity to form and maintain and access social networks that can buffer the effects of stressful life events. Unfortunately, people who are impoverished or people who have low-income jobs sometimes do not have access. Their jobs may not provide psychological or sociological support. So thus, they have to figure out these things on their own, and they may not have a community or support system to help them to do that. Next slide. As you can see, these stressors continue to exacerbate for people of color. Next slide, please. Survival. For low-income individuals, survival or scarcity stress is chronic. Having few personal financial resources or living in a community that lacks basic services can lead to worry and instability. Small hiccups can become personal catastrophes of people already struggling. Car problems, for instance, can turn into a loss of a job. This sort of worry isn't just another inconvenience. It makes people sick. Survival stress experienced by low-income individuals is biologically distinct from other sources of stress and brings about toxic hormonal responses and metabolic changes that leave people susceptible to disease and poor health. I cannot tell you how many times I've met people who are surviving on a day-to-day basis, trying to make sure that they have the means to eat, to support their families, to care for themselves, to care for a loved one, but especially during the pandemic, trying to find a job, locating a job, how I'm gonna get to that job, all those other things that come. And as we all may see that something that's as a minor hiccup for us becomes a major, huge life catastrophe for so many others who don't know how or don't have the wherewithal or the skill set to deal with how do I achieve or how do I approach this as small bites as opposed to feeling I have to tackle the entire problem and one thing at a time, as a whole. So those things continue to exacerbate survival, daily survival, things that we take for granted, others do not take for granted because they are essential for them on their day-to-day living. Next slide, please. So one of the other things we found is that racism and segregation, as I said before, plays a huge part in how we experience persons who are exacerbated by their racial experiences in America, but also here in Columbus, particularly during the pandemic, given the connections between poverty and health and poverty rates for Black Ohioans are 2.6 times higher than white poverty rates. It is no surprise African Americans in Ohio are less healthy on average than white Ohioans. However, the difference between the health of Black Ohioans, suggesting there is more to the health story than just poverty itself, the health divide between Black and white Americans have been attributed to not only economic disadvantages, but also racial barriers faced by the Black community. Telling Black people to eat healthy, and I tell you, what you mean I don't eat healthy? I bake the chicken instead of frying it, but I'm still gonna put a little gravy on it. Or I'm gonna put a little hot sauce on it. You know, those types of things. You know, it's just cultural and things that we do that help to maintain some of those cultural aesthetics around health. Yes, if everyone can afford to be eating healthy, if only some of the grocery stores in some of those neighborhoods provided even equitable vegetables and fruits, and gave them at a price that people can afford to buy them, or you know, so again. Cultural. This is why it's important to have social workers and psychologists, psychiatrists who understand the cultural nuances of health disparities, particularly when it comes to food and food depravity. That made me say the wrong word. Depravity and all these other things. Ohio has a serious housing segregation problem. As a state, Ohio ranks 8th worst in the nation for Black-white residential segregation. Cleveland and Cincinnati are two of the most segregated communities in the nation. Higher rates of concentrated poverty and racially segregated communities create a feedback loop of generational poverty that is amplified by a lack of resources in those communities to ameliorate health damaging conditions and create health enhancing opportunities. So there's not only just the food deserts that exist there, but no access to resources, socioeconomic resources. There are no health resources, so they don't have those type of things that are readily available to them. Sometimes people who don't have access to transportation or find themselves axed out or unable to get into other areas to exacerbate, to prevent the exacerbation of those health conditions in their lives. So having segregated neighborhoods, also people feel less safe. They're policing those communities more readily, but also segregation produces health damaging neighborhood conditions, anxiety, stress. People are angry, people who are dealing with so many other things in their lives, creates a community that is always on high alert in its own anxiety and its own stressors, which can exacerbate other people's stressors. So sometimes in turn, these segregated areas have high rates of unemployment, low wages, and the chronic stress associated with all these factors. I'm not telling you all nothing new. I know that, nothing new. What do we do and how do we resolve this? It's something that again, as I pour through all of the materials that I've been reading through all of everyone's Columbus Public Health, state, the government, public policies, and racism and other public health crises. Racism has always been the underlying mitigating factor when it comes to dealing with how we deal with health in Columbus. So if we've been knowing this, if we have all this data and all this information, what do we do next? How do we prevent? How do we move forward to the next level where we're not dealing now with the cops to go to the table with critical race theory and how it impacts the way we learn about race and not allowing our children to understand how racism works, to prevent ourselves from not allowing to get into these conversations, engage into these conversations. Are we allowing ourselves to continue to perpetuate what we already know? To say we did the data, we had some health experts to come in and talk about it. Where are the resources? Where are the funding? So I hope, next slide please. What this prevents, what I understand, ultimately are the social determinants of this. So economic stability, neighborhood and physical environment, education, food, community and social context, healthcare system. All of these are interwoven within one another of how we deal with our societal, but also socioeconomic implications of race, and making sure that people of all colors and all races have access, not just to employment, but also to housing, also to education, to food, to community engagement, and the healthcare system. How do we get these all working together, intertwining, to make sure that we all have access to them, making sure that all persons are not exacerbating these healthcare issues of high blood pressure, obesity, diabetes. Engaging these in material ways. The last slide says it's simple. Listen to Black people. Listen to Black people. I want to go further. I really want to read more Du Bois, but if you have questions, I have some more readings that I want to give to you all.
Thank you so much, Dr. Dean, and thank you for staying after the appointed hour. Thanks to everyone who has stayed on too. We very much appreciate it. I think we especially appreciated how much you focused on the impact of stress and trauma as well. I think you really brought to life much of what we see in the data. It's clear that the relationship and the relationships between racism and health are very complex and intertwined. It does take diligence on all of our parts to continue to listen and learn and seek to understand all of those complex interactions, because it's it is very difficult to get one's head around just the data, but then also what we need to do about it. I think your words at the end there are well put, that we need to move from data to action. We do know a lot about what works to improve health, what works to eliminate health disparities. And we know that there have been actions, you've cited many in your presentation today, that state and local policymakers have already collaborated on decisions that create a level playing field for every Ohioan, starting with declaring racism a public health crisis, but even going further than that, in particular, an effort to reduce racial disparities related to infant mortality.
Yeah.
We know that we need to have continued focus, effort, investment, and partnership between the public and private sectors to ensure that every Ohioan has the opportunity to reach their full health potential.
Yeah.
Dr. Dean, I don't see any questions for you, but I see a lot of appreciation in the chat. One person said, great presentation, details on anxiety and mental health and stress are important. Several people said, thank you, wonderful insight. I think we'll let you go on to your class here, and I'll close us out for today by saying that you all will receive an evaluation form. We hope you'll take a few minutes to complete that after today's forum. We very much appreciate your engagement all throughout today. We look forward to continuing to work with you. Please reach out if you have any questions for us as you engage in your organizations and work to eliminate racism and achieve equity in our state. Thank you all and have a great afternoon.